Just a bit of an introduction. He needs no introduction. The esteemed Professor Omar Usmani, he is the Professor of Respiratory Medicine at the National Heart and Lung Institute in Imperial College, London. He's a consultant physician at Royal Brompton Hospital and St. Mary's Hospital, London. He's the Clinical Director, Respiratory Trials at the Imperial College Respiratory Research Unit. His research themes are inhaled drug delivery, small airways physiology, lung imaging, respiratory pharmacology, and telemonitoring and e-health. His specialist areas are asthma, COPD, and chronic cough. And he's the group leader in the clinical research group in the small airways section at NHLI and a principal investigator as well. He is an international authority on aerosol medicine and inhalation medicine, and his research has fundamentally contributed to the understanding of therapeutic aerosol deposition and clinical effectiveness in inhaled drug delivery to the lungs. He's the co-director for Imperial Network of Excellence in Aerosols and Health. Moving forward, in 2015, Professor Usmani was awarded one of the highest accolades in aerosol science, the Thomas T. Mercer Award from the American Association of Aerosol Research and the International Society of Aerosols in Medicine, recognizing his international research excellence in pharmaceutical aerosols and inhalable materials. He first attended the International Society of Aerosol Medicine in 2001 and presented his initial findings from his doctoral thesis, and 20 years later he was elected as member of the position on President-elect of ISAM. He was awarded the Fellow of the ERS in 2019, and in 2017 he became the Secretary of the Assembly, and it was voted by the members of the Assembly 5 as head of Assembly 5 airway diseases, asthma, COPD, and chronic cough. In 2022, he was the recipient of the prestigious ERS Teaching Award, and he's also a committee member of the ERS Examination Committee in Adult Respiratory Medicine. He holds various international positions of esteem as well. He's the chair of the UK Inhaler Group. He was also in the steering committee member of the Small Airways Working Group for the World Allergy Organization, the vice chair for the drug delivery to the lungs, and the European liaison officer of the International Society of Aerosols in Medicine. He's the board member of the Aerosol Drug Management Improvement. So without further ado, I would be checking the comms. We do have Professor Usmani online.
Dr. Taber, thank you very much for that introduction. I hope you can all hear me really well.
Welcome. Just 1 minute housekeeping. Please sit down, and please, anybody wish to talk can leave the room. Please sit down. Be quiet. Thank you, Professor Usmani. It's Professor Javed Khan from Auckland University here. Welcome, and we are all keen to listen to your talk. Thank you.
Well, thank you very much, Professor Khan, and also to Dr. Taber for that introduction. Apologies I can't be there in person at this arena. I'm sure you've got a very interesting program, and all the best for the ChessCon Congress, and also to the Pakistan Chess Society for the invitation. So I know some of you were at the ERS last year in Milan, and this year you know it's in Vienna, and I talked about small airways, and very much what I want to do is link the science with the clinical relevance of the appreciation of small as target the small airways if we believe that the small airways are actually important. And then 3, very much transforming the small airways. What's the evidence that if we actually treat the small airways, we can benefit our patients with asthma and COPD? And I'll be giving you the evidence and the science behind all of this that will translate into our clinical practice. So let's start off. What do we understand by small airways? Well, they're actually defined as airways less than 2 millimeters in diameter. So I'm not talking just about the asthma compartment. I'm actually talking of a quite a proximal zone, which starts at generation 7. So you know, when we do bronchoscopy, we can see generation 3, 4, sometimes 5. So we're only talking about 2 or 3 further generations beyond what we can see by the bronchoscope. So generation 7 to 16 is the conducting zone, small airways, and then 17 to 23 is the asthena, small airways. So again, what I want to say is when we talk about small airways, it's not the asthena, just the asthena component. it's actually generation 7, which is quite proximal. So we published a state-of-the-art review with Meilan Han from the US and James Hogg, and some of you will know of James Hogg's work over the last 60 years and his contribution to understanding small airways and COPD. So time doesn't permit me today to go through the 7 pillars, as we said, of small airways disease and asthma and COPD, but I will be focusing on the link between pathology, pharmacology, and physiology. So let's start. What do we understand about the pathology?
Recording in progress.
What do we understand about the pathology in asthma and COPD? We were all taught in medical school that asthma is a disease of large airways, and you can see on the right-hand side, smooth muscle hyperplasia, mucus plug, and inflammation contribute to the large airways. But the pathologists have said, wake up, pulmonologists, asthma is a disease also of the small airways. It's the whole airway tree. So those same pathological features are present in patients with asthma, and they have small airways disease as well as large airways disease. So let's now look at a study I always show. It is old, but it's a seminal study by Qutayba Hamid, and he showed asthma inflammation involves both large and small airways. So what did he do? He took endobronchial biopsies, which is in blue, and transbronchial biopsies, which are in red, and irrespective of the x-axis cell, you can see that the blue and the red bars are almost equivalent. So that tells us that those cells are proportionally present in equal amounts in the large and small airways. So the pathologists have said to us pulmonologists, you guys should be thinking about inflammation involving the whole airway tree. Surely you need to treat the whole airway tree. And also, we mustn't forget the really upper airways, the nasal cavity. So we've got 3 compartments, the nasal, the large, and the small airways that need to be treated. Now let's move on to COPD. So the definition of the GOLD directive clearly says that COPD is a disease of small airways. Now you and I see that every day, day in, day out, with patients who have hyperexpanded lung fields, flat hemidiaphragms on their chest radiograph, and a high respiratory rate with pursed lips breathing, all features of small airways. But if we look at the pathology, it's clear to see that COPD is a disease of small airway. So this is Jim Hogg's paper in the New England Journal of Medicine 20 years ago, and he did biopsies of airways less than 2 millimeters in diameter and saw 3 things. And you can see first that small airways inflammation is present even in mild disease. So this is a key point, that small airways is not just a disease of end stage, it's present in mild COPD and mild asthma. Point number 2, inflammation worsens with worsening disease severity. And point number 3, which is a topic that's very topical now, we showed it 20 years ago, that eosinophilic inflammation is also important at all stages involving the small airways. And again, I draw your attention that the small airways are generation 7 and beyond. We're not just talking about the acinar component. So we know that small airways are also the major site of airflow limitation, not the large airways. And it is this disease in the small airways that leads to the trajectory that you see here of air trapping and lung hyperinflation, decreased FEP1, which is actually quite a late sign, and then physical deconditioning, dyspnea, exercise capacity limitation, and disability. And actually, Jim Hogg also published some work on mucus plugging in small airways and its relationship to mortality and death. So the pathology and the physiology is really clear that the small airways are important in asthma and COPD, and actually us pulmonologists should not be ignoring this compartment. So let's now move on and ask the question, if we accept that, what is the prevalence of small airways in our patients with asthma and COPD? So the right-hand side is the state-of-the-art article that we wrote, and I showed you the 7 pillars, and we talked about advances in probing the deep lung for small airways disease or small airways dysfunction. On the left-hand side, you see an article that we wrote almost 10 years ago now that divided the assessment into imaging, biology, and physiology. Now, time today does not permit to go through all of the features, but I really want to show you the exponential increase in the utilization of techniques for assessing small airways, because everybody says we find it very difficult to assess small airways. Well, we'll talk about this possibly in the Q&A, that simple spirometry can tell you small airways dysfunction, obviously body plethysmography, but also the technique of oscillometry and impulse oscillometry, which I know is gaining traction globally, not just here in the UK and in the US. And this is the technique where, and many of you may be, or some of you may not be familiar with, essentially it is a tidal breathing maneuver. So how does this work? Well, imagine that you have a loudspeaker that's like a submarine that's sending sound waves down to the seabed that get reflected back up. And the time it takes for those sound waves to go from the submarine to the seabed, back to the submarine, you can work out where the seabed is. So imagine now you have this loudspeaker, the submarine, sending pressure waves into the airwaves, which is the sea. They hit an obstruction, the seabed. You can work out the level of that obstruction based on the frequency of pulsation of the pressure wave. And you can work out whether that obstruction is proximal in the large airways or distal in the small airways. So the technique can be done in children as young as 2 and in elderly patients up to 90. And you and I know that children and elderly patients struggle with undertaking spirometry. They have fatigue and they find the maneuver difficult because it's a forced expiration. This is a tidal breathing maneuver and it's completed in 30 to 40 seconds. And now this has been translated. So there are 7 machines available across the world, and this has been translated now into a recent publication that I thought would interest everybody here, with minimal clinical important differences on changes in oscillometry with respect to asthma, but it's also been used to actually understand and determine small airways disease and small airways phenotyping. So let's move on. What is the prevalence then of small airways disease in asthma? And this study that we did with Dave Singh shows that actually it's 50%. What does that mean? Every second patient that you see in the clinic will have small airways disease that potentially will be contributing to their symptom burden, their asthma control, their asthma attacks. So we really need to think about treating the small airways in those patients, and not just severe, not just moderate, but also our mild asthma patients. So every second patient. Let's now look at COPD. Similarly, the technique of impulse oscillometry that I've described to you was used to look at the old classification of GOLD A, B, C, and D with respect to the prevalence using oscillometry. And you can see with GOLD A, it's 49%. Again, every second patient with COPD, even with mild COPD, will have small airways dysfunction. And that rose to 96% in GOLD B, so almost all patients. And again, we clinically see that in our patients. We see the emphysema, we see the destruction, we see the hyperinflation, we see the flat ME diaphragm, as I've talked about. So it's quite clear every second patient with asthma or COPD will have small airways dysfunction. But that's clear. So let's then move on. Should we consider small airways as a phenotype? So when we have a patient with asthma who loses control or comes to our clinic, they say, look, I'm not feeling very well. We obviously think about the pharmacology. We think about pollen, pollution. We think about vocal cord dysfunction, gastroesophageal reflux. We think about anxiety. We also look at osteoporosis in our COPD patients and heart failure. So we look at the comorbidities. Maybe small airways should be thought of as a comorbidity, as a phenotype that is actually influencing the control of our patients with asthma and indeed COPD. So I want to show you some data now from the Atlantis study, and I'm sure that some of you will be aware of this. So the Atlantis study looked at 900 patients with asthma, and it essentially was asking the question, can we phenotype small airways disease? And if we can, and we identify such a phenotype or comorbidity, what are the markers that can help us identify this? So in 900 patients, biopsies were done. So bronchoscopy was done. Endobronchial, transbronchial biopsy, pheno, nitric oxide, full lung function test with body plethysmography, nasal swabs were undertaken for nasal nitric oxide, CT scan imaging, and impulse oscillometry with multiple breath nitrogen washout. So advanced techniques at looking at large and small airways physiologically. And what did they find? Well, they found very interestingly that 3 key indices, when put together as a composite measure, were able to identify phenotype small airways disease in patients with asthma. And you can see these circled in blue. You can see that it was the R5 minus R20, so that's the 5 Hertz gentle pulsing resistance of the oscillometry, minus 20 Hertz, which are fast pulses. Then you can see the FEF 25 to 75. Clearly, we can get that from our spirometer, and also a decrease in the FVC, forced vital capacity. So actually, when the spirometer was built over 175 years ago, and we recently wrote an article on 175 years of the spirometer, the initial measurement was not FEV1, and it wasn't the ratio of FEV1 FVC. It actually was VC, or SVC, slow vital capacity vital for life. And we seem to have forgotten SVC from spirometry, but SVC, or indeed FVC, are very good indirect surrogate markers for small airways disease. So as I said earlier, in the spirometry, we can use FVC, SVC, FEF 2575, and in COPD, FEV3 and FEV6. Again, two indices we seem to have forgotten about, but they give us the tail end of the expiration that our patients undertake where they've got gas trapping. So 5 measures, 5 indices that can help us from a spirometer if we don't have access to body plethysmography or indeed to oscillometry, that can help us. So this were the key findings from the Atlantis study. But more importantly, and just published last year, or indeed 2 years ago now, Monica Kraft showed that the 2 best indices that correlate small airways disease to exacerbations are RBTLC, which is the gold standard of hyperinflation from body plethysmography. You see that circled here in red, but also the R5 minus R20. So the Atlantis data clearly shows in asthma that small airways is a phenotype, and we as clinicians need to think about that, and also that small airways correlates with asthma control and disease exacerbations. And this was the first large study to actually show that, although there have been smaller studies before. So this is quite clear. So if we recognize the pathology, we recognize the physiology, we understand the prevalence, and we are quite clear now that this is a phenotypal comorbidity, shouldn't we be thinking about treating the small airways? And so how can we do that? And here, there has been a lot of evolution in design of technology and also in formulation science that has allowed us to have the devices that can target the whole airway tree. This is the problem, not just for you in Pakistan, not just in Asia, and not just in other parts of the world, but also for us in the UK and in Europe. The problem is that the majority of the inhalers that we use are very good at targeting the large airways, but they are not good at targeting the small airways. And may I put it to you, by not treating the small airways, may that indeed be contributing to the poor asthma control that we see in our patients and the poor COPD control. So that aerosol deposits in the large airways, but is not able to be pushed beyond generation 6 into generation 7, 8, 9 to be able to treat that very inflammation that we've seen from the pathologist, that biopsy data from Qutayba Hamid, that biopsy data from Jim Hogg, that the small airways are inflamed, have inflammation, have eosinophils, have mucus, have airway bronchospasm. So we need to think about that. Should therefore we be targeting the small airway? So as part of my PhD, I showed I asked the question, if you change the drug particle size, and this was an independent study undertaken, if you change the particle size, can you actually achieve 2 things? 1, better lung deposition in the lungs, but 2, better peripheral small airways deposition if we recognize that pathologists for 60 years have told us that small airways are important. And I hope you can visually appreciate going from left with smaller particles to right large particles, that when you use smaller particles, you achieve 2 things. 1, better deposition throughout the lung compared to larger particles, and 2, that deposition of aerosol reaches the small airways, where it doesn't with 6. And concentrate now on the 6 image. 6, 5, 4, 3, these are common particle sizes that we use in our everyday inhalers. And you can clearly see that they're not targeting the small airways, and there is less total lung deposition. So the science here shown for the first time in patients with asthma using therapeutic inhaled aerosols clearly showed the differences between particle size and lung deposition. And we went on to then show in COPD the similar effect, that smaller particles achieve better total lung deposition and better penetration So PI is penetration index. The higher the ratio, the more the aerosol is penetrating throughout the large and small airways. So this has now been translated to 2 or 3 companies now developing small particles. You'll remember cyclazamide monotherapy, the Respimat inhaler allows you to target small airways, but really the leader globally in the field is Chiesi with Foster, ICS LABA being beclomethasone and the LABA being formoterol. So what do you see here? You see the NextHaler, dry powder inhaler, which has particles of 1.5 for both components, and the meter-dose inhaler, which again has particles of 1.5 for both the ICS and the LABA component. You can see here on the graph other combinations of ICS LABA, and you can see that their particle size is higher, 3, 4, 4.5. So again, those are the everyday inhalers that I was talking about that we use, and they may not be targeting the small airways. And our patients, what happens? They come to us, they say, look, this drug is not working. And what do you and I do as clinicians? We increase the dose. But that dose we increase in that same device goes to the large airways. So actually we're poisoning our patients. And there comes a point in time when they go from step 1 to 2 to 3 to 4. And what they probably need is a change in the inhaler device. Yes, I understand adherence, compliance are important, and we'll talk a little bit about technique. But the key point here is that they need an aerosol that can be targeted throughout the whole airway tree. Another tip, clinically, that I tell all my patients with asthma is when they exhale via the nose. Don't exhale via the mouth. Why? Because in those asthma patients who have upper airway symptoms, that steroid that's being exhaled via the nose will also help their nasal inflammation. And I also say that to my patients with COPD. Why? Because a lot of COPD patients, or 20%, have mucus in their nose. So that exhalation will help the nasal inflammation and the nasal mucus plugging. So I digress, and going back now to deposition, you now have Trimbo, and Trimbo in Pakistan with the ICS LABA LAMA, and here you have beclomethasone, formoterol, and the LAMA is glycopyrronium. And here the particle size is 1.1. This is the first global extra fine triple that's actually been available. Certainly in the UK, we've had it now for 4 years in asthma, in COPD, and also in asthma. But if we move to Foster, that you are familiar with because you've had it there for a while, if you ask the question, what is the lung deposition of Foster? Well, from both the MDI and the DPI NextHaler, first of all, you can see that the deposition is 40 to 45%, which is what you would expect from a small particle. And that aerosol that reaches the lung is targeted smoothly and evenly throughout the large and the small airways, exactly where we want to target. A point I do want to make about this slide and the talk in general, I'm not just talking about targeting the small airways. We need to target the large and the small airways. It's the united airway hypothesis, the area of inflammation that's a carpet throughout the airway tree. And you can see that you get good proximal and distal airways targeting with Foster. So now then, let's move on to have a look at Trimbo. So this is a study that we published just a few years back, and it was an interesting experiment, I think, scientifically. So what we did was we compared an extra fine triple with a non-extra fine triple to understand, does this hypothesis of being able to target the whole airway tree work with an extra fine triple as well? And that study hadn't been done to date. So let's delve into the study in a little bit more detail with this slide. On the left-hand side, you see the extra fine triple of Trimbo. So this is a meter-dose inhaler of beclomethasone, formoterol, glycopyrronium. It's an extra fine formulation, and you see a representative visual image of the patients. On the right-hand side is a non-extra fine triple dry powder inhaler of fluticasone, furoate, vilantrol, and umeclidinium, and you can see a representative visual image. Now, if we just stick to the images from what I've shown you from my work, you can see that the left is lighting up more than the right. The extra fine is lighting up more, you're getting more in the lungs, and that deposition of aerosol is going to the large and small airways. But let's actually look at the numbers now in the analysis. So if we look now at the different components of ICS LABA LAMA, you can see, and here we've switched it. So it's now not PC ratio, but CP ratio. This is just the way that the data was presented and analyzed. So here, the lower the ratio, the more the even spread of the aerosol throughout the airways, you can see two things. First of all, you see a lower ratio of 0.5 on average. And the second point, you see that ratio is consistent. Now, with the dry powder inhaler device of the triple that's non-extra fine, you see much higher ratios, almost quadruple. So that means large airway targeting or distal airway targeting, but also that you see the three moieties of ICS LABA LAMA, they are different. So that means there's variability in the pharmacological position of the ICS LABA LAMA, whereas here there's consistency, suggesting there's congruency or symbiosis for the three drugs on reaching the whole airway tree. Wherever they deposit, they're depositing together. So that was another interesting finding scientifically from the study that we did. And we've gone on now to look at the triple therapy in asthma, where it's licensed. And this is the STORM study. And really, from the images that you can see now, and I think it's quite clear, we saw greater deposition with the triple in our patients with asthma. And we also looked at ventilation scans. And here we compared it to healthy volunteers. Now, everybody says, we get that. We get you get more deposition. We see that it's deposition throughout the airway tree, but don't you exhale all those small particles out? And the answer is no. We all know that the lungs are an upside down tree. We have the tree trunk, which is the main bronchus. We've got the bronchi, which are the branches. We've got the leaves, which are the alveoli. It's an upside down tree. And these branches, they're not one straight tube. They actually have bifurcations and they are tortuous. So when you inhale, you deposit, but when you exhale, you also deposit. You don't exhale via a simple tube. You exhale via these branches and you get deposition on the way out. And I showed that with a physicist colleague of mine, Professor Verbank in Brussels a few years ago. But I looked at all the data that was available in the public domain, and here I've grouped it into the top panel, small particles. So here, you've got sclezenide 1.1, Foster 1.5, QVAR 1.1, and larger particles 2.4, 3.5, 3.7, and in blue you see the deposition. So look, on average, small particles 3-4%, large particles 2-3%. So it's only a percentage-wise difference, which doesn't make any difference. And you can see that there's better deposition of small particles in the airways than there is large particles. So I just want to dispel that myth that you exhale all these small particles. We've talked about deposition. We need to talk about the device, because there were differences, weren't they, between an MDI and a DPI? And a lot of us assume that DPIs are all the same, and therefore we should be prescribing DPIs. But I want us to put a break there. So, a metered dose inhaler, the biggest problem is our patients do not inhale it slowly and deeply. So, what do I mean by slow? What do I mean by deep? So you ask the patient to exhale, to lift the chin up, and to inhale over 5 seconds. So it's slowly, deeply, comfortably, naturally, gently. And 5 seconds is a long time. And actually, when you explain that to the patient, it's a light bulb moment, because then they're not messing around with their thumbs or trying to actuate and inhale at the same time. You just say, start to actuate, then you've got the upstroke of your inhalation that lasts for 5 seconds, followed by a breath hold pause. And time and time again, it's recognized that the incorrect maneuver has been taught to patients. Now, dry powders, you need the opposite. You need a forceful, deep, quick, hard inhalation. Why? Because you need to drive the powder out of the device for the majority of DPIs. Why? You need to do 3 things. First, you need to pull the drug in the device off its lactose carrier. 90% of devices are these. You have 10% that are reservoir devices. 2, you need to break that powder. 3, you need to carry that powder past the throat and in the lungs. And it's clearly recognized that some devices require flows as high as 60 liters per minute to activate them. Now imagine your patient cannot achieve that. Obviously, they're not going to get therapeutic benefit from the pharmacological drug, which is not reaching the airways. And actually, where does it go? It goes a lot to the throat. So another clinical tip, if you have patients who cough after using a dry powder inhaler device, think carefully about that device, whether it's right for them, because throat, and yes, it's candida, but I'm not worried about candida. What I'm worried about is throat tells me that that steroid has access to the systemic circulation via the esophagus, via the stomach, and via the liver. So for me, throat candida is always a warning sign that there is systemic delivery of that steroid. And I see that a lot with dry powder inhaler devices. And this was an electronic study done by Suleiman and colleagues in Richard Costello's group in Ireland, and used absolute clear monitoring using digital add-ons to a dry powder inhaler device. And they looked at the number one or the top errors. And you can see on the x-axis the variety of errors in dry powder inhaler devices. And this was accurate monitoring undertaken on these patients in their home environment over a course of 2 to 4 weeks using a digital electronic acoustic device. And the number one frequency, nearly 50% of patients had low peak inspiratory flow, and in asthma. So it's not just in COPD, in asthma as well. Your patients cannot suck in deep and hard at the requisite flow to activate their dry powder inhaler device. So this was written by John Pritchard a few years ago, that actually DPIs are contraindicated. So provocative, but actually probably to make people wake up and think about their clinical practice, that DPIs are really not useful in the very young, the very old, or indeed the very ill. In your national guidelines, in the UK national guidelines, if for an acute asthma attack, we don't say give a DPI at 2 o'clock in the morning, we say give a meter-dose inhaler with a spacer until the ambulance arrives, and then they'll proceed with that, or indeed give a nebulizer. Although I have to say, studies were done 20 years ago, and you're very familiar with Martin Partridge, who was a great supporter of the Pakistan Chest Society, undertaking some work probably in 1996 that showed actually a meter-dose inhaler via spacer is as effective as a nebulizer in the acute situation in the ER. So moving on then, this table clearly shows you different dry powder inhaler devices that you're familiar with, and you can see them all listed here. And then you've got minimal peak inspiratory flow rates and optimal. I've just told you that 50% have less than 35 liters per minute. And it always surprises me that the drug industry, the pharmaceutical industry, write minimal and then optimal. Surely the optimal flow is what's required for our patients. Well, the answer is yes, it is. And the optimal flow will get that drug in the lung. So you can see that sometimes the optimal flow is double the minimal flow required. And that suggests that actually that device is flow dependent. In contrast, the Nexthaler dry powder inhaler device, and this is again an independent paper by Ghosh and colleagues, showed that the minimal is the same as optimal. So how does that translate again clinically to my patients? I have confidence that when I give that device to my patient, even if they have a lower suboptimal flow compared to other devices, they will be able to activate and trigger this dry powder inhaler device, achieve proper drug delivery, and another advantage and another key advantage is that it's extra fine and delivers throughout the large and small airways. So actually this dry powder device by Nexthaler, and again, one of my areas of expertise is aerosol science, but I have to tell you is real progressive engineering that's led to this device. The formulation science together with the device engineering technology, the mechanical engineering that's actually allowed this device to come to be used for our patients. And the other point I say is whenever you meet people from the pharmaceutical company, whoever they are, and they're talking about their dry powder inhaler device, I'd recommend for your patients for you to use flow-independent devices rather than flow-dependent. So what do I mean? Look at the x-axis here, typical flow rates of our patients. Your patient with asthma or COPD, when they're at rest, they'll be okay. But say they've just had an exercise session, or they come back rushing from work, or they're climbing a flight of stairs and they've got to take their inhaler, their respiratory rate will change. And as their respiratory rate changes, so does the ability of their thoracic cage, their respiratory muscle excursion to be able to generate flows. So patients will have different flows. Sometimes it will be 20 liters per minute, sometimes they'll achieve optimal flows of 60. But it's that low flow that we really want to safeguard against. Safeguard in the way that when they have a device, that it delivers consistently at that same dose as high flows. And you can see that here clearly for the Nexthaler device, that at low flows or intermediate flows or high flows from 20 to 90 liters per minute, you're getting consistent dosing. So always look for that parallel y-axis straight line from any DPI that you look at that will show you that the device is independent of the flow of the patient, and therefore you can be confident that irrespective of the patient's exercise tolerance, ability, respiratory rate, they will achieve consistent dosing. So let's then now move on to pharmacology and to drugs. And really, I think I've only got about 10 odd more minutes, so we're well on time with the presentation, and talk about the importance of that. So we've seen about device technology and inhaler technique, and I'll come back to technique. Well, we've talked about it, haven't we? Inhale slowly and deeply for an MDI, and actually for most DPIs, you've got to inhale really hard, fast and quick for at least 3 seconds, and if your patients don't do that, then they're not getting enough from the majority of DPIs. And now let's move on. PMDI solutions, and everybody thinks PMDIs, they're old, we've had them for 50 years, DPIs are better. Well, that's not the case. And I'm just going to show you some data now on PMDI solutions being actually better than dry powder inhalers using the same ICS-LABA dose. So on the left, you see asthma. On the right, you see COPD. These are real-life effectiveness studies, so they're not randomized controlled trials, but real-life use of patients on patient-reported outcomes. And they were both done by David Price's group, who's now based in Australia and Singapore. And on the left-hand side in green with asthma, you can clearly see that they utilized the PMDI of fluticasone salmeterol versus the DPI fluticasone salmeterol, and actually found that the MDI favored better measures in asthma control and treatment success. On the right-hand side, they used the same fixed-dose combination of fluticasone salmeterol delivered by an MDI versus a DPI in COPD, and again, you can see that it favors the MDI with respect to exacerbations. So the real-life data is clear that actually MDI are not inferior to DPIs, and indeed here superior in terms of real patient-reported outcome measures that actually matter to our patients. Our patients don't come to us and say, my FEV1 today is better, as the randomized controlled trials tell us. They say, I have better asthma control and I have less asthma attacks or exacerbations. So this was a nice study. And I very rarely show preference studies because they are always funded by the pharmaceutical companies to tell us that their product is better. This was an independent study by a university in Japan that I visited, and Muriaki and colleagues. And what they did was they compared, and you can clearly see here in this pie chart, they compared a dry powder inhaler of fluticasone salmeterol compared to a metered-dose inhaler of fluticasone salmeterol in patients with asthma, and they gave both drugs in that trial for 2 months to the patients. And the question, the research question they asked is, which inhaled corticosteroid, you see this in the title of the paper, and LABA is better in patients, a DPI or an MDI? And guess what? You can clearly see now that nearly 60% of patients preferred the MDI compared to 35% the DPI. So they did measure FeNO, they did measure spirometry, they measured lung function, they measured asthma control, and actually the MDI did as well as DPI on these measures. But when the patients were asked, they preferred the MDI. So the Japanese group, which is primarily a DPI prescribing country, actually wrote, maybe we should think about incorporating what our patients want and think about prescribing them an MDI. And it wasn't one against the other, but really about the wake-up call and dispelling the myth that DPIs are better than MDIs. So let's now move on to point 2. Improperly designed devices, as well as incorrect use, can reduce the delivery of medication and impact its safety and effectiveness. I've already told you about candida in the throat being a local complication, but also systemic bioavailability via the GI tract. If you have a device that is incorrectly used and it's depositing all the drug in the throat. So you really need to think about that. But the problem is, you and I, we are never trained about inhaler devices. This is a study by Vincente Plaza. Look at the table on the left-hand side. In over 6,000 pulmonologists, allergologists, primary care, secondary care, medical students, medical residents, physiotherapists, nurses, nursing students, pharmacists, pharmacist students, and technicians, in over 6,000, when they were assessed, shockingly, only 12% in the bar chart on the right had knowledge of inhaler technique. Put that another way, 90% of us do not have correct inhaler knowledge to be able to tailor the device to our patients. And the reality is, we're all taught about drugs and receptors and pharmacology and cytokines and interleukins in med school and physiotherapy school and nursing school and pharmacy school. We're not taught about the device. Yet every day, whether we're in the intensive care unit or in community or in primary care or in secondary care, as respiratory subspecialists and specialists, we will write a prescription where half of that is the device. Yet shockingly, we're not taught about the interface of the device. You may have the world's best molecule, but if you're unable to relay that information to the patient and get that patient to use that device properly, then actually, you know what, that molecule is useless. And yes, I get it. We're seeing 90 to 100 patients probably in a clinic, and we only have 3 to 4 minutes with that patient. And everybody will say time. We need the time to be able to teach our patients. And so certainly in some countries, and I was just speaking to Turkey the other day, they've used certain documents in terms of advocacy to try and actually get dedicated specialists, physios or nurses that can train patients where the time is difficult for our patients, for doctors. And indeed, this is one document that's being used, and I use the term device detected. So there are 3 points from this systematic review that I undertook. First, we all need to be device detectors. We all need to spot incorrect inhaler use. Why? Because we show that even one inhaler error in asthma, even one inhaler error in COPD leads to 2 things. One, it leads to a burden for the patient with poor disease outcomes in asthma and or COPD, and a burden to our health economic society. In that, poor technique, patients will end up in the ER, and that will be a burden to our ER department and or our hospital bed, irrespective of whether they've got a viral exacerbation or a pneumonia or a little bit of heart failure. The poor technique of that patient, the incorrect inhaler use, we're actually seeing patients do get admitted to the ER. And there was a very nice study, I'm not showing it, done by Chi Lo in the States when he was doing a sabbatical in States. So he's in Singapore, I was there recently, but he was in the States, and he showed that actually the 30-day readmission rate for patients with COPD who've come in with an acute admission that are discharged with a DPI is 50% compared to a nebulizer. Now in the States they use nebulizers more, we don't in the UK, and I have views on the use of nebulizers, I have to say. So the DPI essentially showed that actually there was a 50% readmission rate with a DPI in 30 days. Now, you may know or may not know that in some states in the US, if you are readmitted within 30 days, the hospital then gets penalized, it gets fined on the proportion of patients that are readmitted within 30, because there's a big drive to stop readmission from diabetes, metabolic disease, from heart disease, cardiac and heart failure, and also from COPD. So you can use this document in terms of advocacy to ask policymakers, to ask government officials in terms of considering that investment in training inhaler technique to patients through a healthcare professional or through a group, and training in the medical school curriculum, the nursing curriculum, the pharmacy curriculum, and the physiotherapy curriculum at the undergrad, indeed at the specialist. I mean, I trained as a specialist respiratory registrar for 5 years, and not once was I taught about devices, but naturally, as you'd expect, I've instituted that now at Imperial. So let's move on. You've got to balance risk assessment and cost effectiveness. And you may say, well, do you know what, Professor Usmani, it's very easy for you to say that, but you've got to take into account cost, and you've got to take into account that the patient, the key issue here is aspects related to cost. And I get that. So in Pakistan, I recognize that Chiesi does have the MDI and it does have the DPI. And you've got Foster in low dose or normal dose and high dose, and you've got that in the Nexthaler. And you've now got the only fixed triple therapy available that was launched last year, the COPD, and you're lucky, you've also got the license to asthma. There are other countries of similar GDP that actually do not have that license for asthma, and it's the only extra fine therapy available in Pakistan. So based on pathology, based on physiology, based on imaging, based on prevalence, it's about relaying that information and giving the patient the opportunity to have that treatment and be taught how to use the device properly. And we recognize the problems with standard DPIs. And here, honestly, I would say that DPI, and I've said this actually in Italy to quite a few people as well, within this corporation and in other talks, that the DPI, the flow of 35 is almost like you breathe as slowly from an MDI. So there's a DPI and an MDI that almost act in the same way. And this is a unique DPI. It's very different to the other DPIs that are out there. I don't need to remind you of the other brands that are out there, or more familiar with them than I are, but I was interested to understand them. And you can see the proportion from data from probably this is a year ago of MDI, of pre-filled DPIs, and of rotacabs. And I appreciate that cost is an aspect here, but we've done videos of patients using DPIs. We're actually doing a 5-year study at the moment that's been funded for $2.5 million US from the FDA, looking at how patients use DPIs. And you and I may teach them to use that in the clinic. As soon as that door's closed, they are used in such a variety of ways that really I'm looking for a device that gives me the confidence that it's independent of flow, can target the large and small airways, and I'm relaying that information to my patients, understandably at a cost, but in the future to help them and also to help the societal burden of the cost of asthma and COPD. I think that really needs to be considered. I was quite surprised of the rotacap used here. I appreciate that in the Indo-Pac region it's used, but I have to say that really surprised me, and I guess cost is the driver. And who am I to stand here and dictate on money and money issues? But really, it surprises me, and maybe collectively there needs to be some thinking behind this. So safety and efficacy of Extrafine is evidence-based, and really that's what I want to do now in the last 5 minutes or so, is to challenge myself to present to you the data of does full lung treatment really matter, targeting the large and the small airways, not just about the small airways in both asthma and COPD. And I'll work through asthma, I'll work through COPD, and I think we'll have ample time for questions. So this is one of the first studies. I'm going to focus on triple therapy because you will have seen the FOSTER data already. And the interesting thing scientifically for me is that the triple data with the ICS/LABA/LAMA, beclomethasone, formoterol, and glycopyrronium actually follows what the FOSTER data in terms of deposition, in terms of patient-related outcome measures. So the Trilogy study, what did this do? And I don't want to just present you a randomized controlled trial and say this drug did better than X and Y and Z. I want to pull out some of the scientific elements on device and Extrafine if we are truly to think that this is going to be better for our patients. So I looked at these studies in a critical way. So this was a study, top arm is triple therapy, Extrafine. I put small particles there, and it's an MDI. And the bottom arm was FOSTER, which is the Extrafine ICS/LABA, plus the so it's FOSTER. So what's the difference? There's a LAMA here, which is Extrafine. There isn't a LAMA here. What do we expect? Of course you expect the triple to do better than the dual ICS/LABA. Of course we expect that in a year's time. We'd be concerned if that wasn't the case. And guess what? We found that, or the trial found, that Extrafine triple led to a reduction of moderate to severe exacerbation compared to Extrafine dual therapy in patients with COPD. That was clear. And you can see here very clearly the hazard ratio and also the reduction in the probability of having a COPD exacerbation using the triple in the blue line versus the FOSTER, so Trimbo versus FOSTER there in the red line. Quite clear, and led to 20% reduction. So let's move on to the second study. This interests me from a scientific perspective. So we've set the scene of triple versus dual, Extrafine triple versus Extrafine dual. So the Extrafine LAMA must be doing something, yeah? Well, that's the hypothesis. And remember, we have non-Extrafine LAMA as well. So this study interests me. It had 3 arms. It had Trimbo, which is treatment A. It had iotropium large particle DPI hand inhaler, which is treatment B. And treatment C was FOSTER plus large particle DPI iotropium. So, the FDA wanted treatment A compared to treatment B, and you will say, of course, triple is going to be better than monotherapy LAMA, and guess what? That's exactly what the trial showed. But I want to present to you a thought that I had when I was reading this study before I came to the result. Maybe we should see a difference between treatment A and treatment C, because this is extra fine LAMA, glycopyrronium, and this is a large particle DPI, tiotropium. I don't know if you guys have Respimat there, but Respimat is tiotropium, but it's high fine particle fraction, so that delivers to the small airways. But this is tiotropium, yeah. So that's what was used, and they used this because of the similarity to treatment B. So what did they find? Well, with no surprises here, there's a significant decrease in time to first moderate severe exacerbation, and again, you can see that quite clearly with Trimbo, treatment A, versus the monotherapy, the DPI. And in this subgroup analysis, I looked at the data versus Trimbo plus Foster plus the DPI. And actually, if you had had more than one exacerbation in the last year, then you actually had a trend towards a better improvement with triple in a single inhaler compared to large particle LAMA plus Foster. So what does that tell me? That tells me the extra fine nature of the LAMA. The extra fine nature of the LAMA must be doing something compared to large particle. Remember, we're not talking about the asana, it's generation 7. Generation 7 and beyond has mucus in COPD, it has inflammation in COPD, and it has bronchomodulatory tone because the acetylcholine muscarinic receptors are present all the way until generation 16, 15. So that interests me. Now, we know in asthma that there have been changes, and I'm not going to be talking about anti-inflammatory reliever therapy, which is in track 1, AIR. You will know that it's been updated in GINA over the last 2 years. So you have AIR only, AIR treatment, and you've got MART, maintenance and reliever therapy. I'm going to talk about step 4 and 5, triple therapy in persistent airflow limitation. And this is the Trimaran and Trigger study. So what is the clinical relevance? You and I often see patients who we have said they're asthma with a bit of COPD, or they're COPD with a little bit of asthma. I'm not talking about ACOS because the S is gone, but here we see persistent airflow limitation fixed. So they could have been patients who are asthma that ended up smoking, that were exposed to pollution, and their airways have modeled in such a way that they've got fixed airflow limitation. They don't have that variability. And this is a group that I think is quite interesting with respect to the triple therapy. So there's a lot of wording on this group, and maybe I need to just redo this slide going forward. But this is PAL, persistent airflow limitation, in asthma, and what did it do? Well, it defined PAL as an FEV1 of less than 80% and a ratio of less than 0.7, and there was no PAL if these criteria were not met, and then they compared PAL on this definition versus no PAL, and they looked at triple extra fine versus dual extra fine, and you can see that actually extra fine triple significantly improved the patient's odds of normalizing airflow limitation compared to ICS LABA alone. So there is something about extra fine, something about triple, and importantly, the extra fine LAMA. Now remember from 10 years ago, the GINA directive that said you can use LAMA now on top of ICS LABA, and they specifically said to use Respimat tiotropium as add-on therapy. So triple has been around for a decade. So here it's interesting that the extra fine nature of targeting the small airways of the LAMA is interesting. Again, I'm pulling out the scientific element. So again, it's a busy slide, but this was another study, and it found that with persistent airflow limitation, extra fine triple decreased exacerbation, particularly those who have got suboptimal control. So another study to give us a support, and this is really interesting, and this is by Alberto Papi and was just published about a year ago. They did a further analysis of extra fine triple versus Foster, and they looked at seasonal variation and found that when you have extra fine triple in patients who have asthma, who have fixed airflow limitation, but describe seasonality, there are reductions in the seasonal peaks. So you don't have these peaks during the various seasons that we recognize our patients are admitted with asthma. So that was another interesting finding from using extrafine. So how can we explain this? And in the last 3 or 4 slides, well, it's not just about improving bronchodilation with LAMAs in asthma. There is mucus beyond generation 7, and Jim Hogg has shown that, and shown that that relates to mortality in patients with COPD, and certainly mucus was really back in fashion now in asthma. Certainly at the ERS over the last 3 or 4 years, we've had